Testing 1, 2. Very good. Okay. All right. So pretty much when we talk about the lumbar plexus, oh, actually before that, review from last lecture. That was a little while ago. Can someone tell me? Let's see. Tell me one of the nerves. Doesn't have to be the last one. Tell me one of the nerves that we were talking about over the past few lectures. Shout out any nerve that we were talking about.
The dorsal nerve.
Good, fantastic. Gotta get another one.
Long thoracic nerve.
Phenomenal, good. All right, so the people who said the nerves you can't answer. So, what muscle innervates the long thoracic nerve? Sorry, what nerve innervates the long thoracic nerve?
It's not a subclavian muscle.
Nope, not that one. Good try, good try. Okay, so we're talking about long thoracic nerve is serratus anterior. Okay, so that was the one. I think Amanda, you said it. What was I heard that one. What was the other nerve I heard?
Dorsal nerve.
Dorsal nerve, dorsal scapular nerve. And what does that innervate, or what muscle is that innervated by? All right. So
Subclavian muscle? No, right?
nope. Dorsal scap. Think of your rotator cuffs.
Is it the scapular nerve?
So we have the nerve already. We're talking about what muscle is innervated by the dorsal scapular nerve.
Is it the subscapular muscle? No.
Nope. So I'm going to pull it up here.
Is it levator scapula?
Levator scapula. I believe you are right, my friend. Good job, Eric. I'm just going to pull it up so you guys can see. Come on. There we go. Dang, that guy right there. All right, just slide this over. Okay, we're talking about levator scapula. Good job, and we're looking at rhomboids major and rhomboids minor. Fantastic, and then thoracic, anatomical left. All right. So serratus anterior. So long thoracic nerve, serratus anterior. All right, good little review. Okay. So when it comes to the lumbar plexus, there are 5 areas. So you have a little bit of a combination from the 12th thoracic nerve along the thoracic spine that combines with the first lumbar. And then you're preceded by the second, third, fourth, and fifth. So what happens is you're going to get this intermingling of nerves and that are associated with one another, just like the brachial plexus. Like I said, I'm not going to go too crazy in depth, but the familiarity of getting to know where these come from, this is where these combination nerves come from. You have very large nerve here, your femoral nerve, very large. You have your accessory muscles. This is more like gluteal area. This is like the leg, lateral leg. Genitofemoral, again, more pubic area. And then you have your inguinal muscles as well. So like I said, the biggest one is here, your femoral nerve. So the one thing that is associated with this is the muscles of the external rotators. So I just really listed just the real deep muscles, your deep external rotators. There are more muscles involved. So you have your piriformis, your superior gemellus, obturator internus, externus, inferior Jamelli and Quadratus Femoris. So these are muscles that help create external rotation of the hip. So external rotation of the hip means if this is my foot, I'm turning out. So that is the rotation of the hip laterally. Okay. So let's see what this. Okay. So I try to come up with something clever, a mnemonic, because it's nice to know that if you know the deep muscles of the external rotators, you can identify that more a little quickly. Please sign over Oliver's Infinity Quattro. Priscilla sometimes orders olives and Jose Cuervo. I kind of like that one that had some alcohol related reference, but that was the only way I could really come up with that one. And then, so I'm just going to try to, for today, I'm just trying to give you guys a way of how to remember it. Um, and we'll take it from there. Okay, so I call these guys the like the forgotten brothers of the Mario Brothers. So Waluigi and Wario, yeah, Waluigi, Wario. Um, these guys are along that pelvic area where your sit bones are, your obturator internus and externus. So when you get tested on some of this, you know, are they really gonna like kill you on L1, L5, L1, S1, L5, S1 distal nerve, and obturator nerve? Pretty much, when it comes down to it, I think of it as you can think of these two guys, O O O. You have the obturator nerve there. So that's the beauty of this muscle. It's you wouldn't be as specifically sure. They'll be like, oh, distal nerve of this branch. All right, let's relax here. All right, it's the obturator nerve. You don't have to go crazy over it. So this is nice because this is where it makes life easier, as they have the same name. So you can't really forget obturator internus externus, obturator nerve. So you'll be fine with that. So these are the original Mario and Luigi guys. So the Jamelli Brothers, I call them. All right, so this one you got to get a little more specific. These attach again along these segments along here, inferior. So you're talking above your greater trochanter area here, and a little bit more above like the pubic area posteriorly. So as you can tell, this is the sacrum back here. So it is very deep to the sacrum. So the the superior one has the obturator nerve branch, and the inferior gemellus is the quadratus femoris. So in pairs, these guys don't have that familiarity, unfortunately. But just always remember that, yes, they have superior inferior, but just remember that these guys have a different nerve operation or nerve innervation. Um, Sometimes I might say like sun, superior obturator nerve. At least if you can help that, you can help the difference with that one. Um, and then let's see, quadratus femoris. That's gonna be associated with another muscle group. But I would say you can remember sun. So if you were to say superior gemellus, sun, superior obturator nerve, might help you out that one. Let's see, yeah, that one. Yeah. Okay, so piriformis. So a lot of you guys have seen the clinic piriformis stretch. The cool thing about the piriformis, it actually works as an internal and external rotator. As we call it hip flexion, as you're bending your hip up toward your knee, once you get past beyond 90 degrees, it becomes an internal rotator. So that's why. So when I was in PT school, I was like, wait, how is it? The piriformis is an external rotator. Why are we doing that stretch? Because that technically is it's an external rotator stretch, internal rotator stretch. But I'm sorry, external rotation. But when you're pulling that knee toward your chest, right, you are stretching that muscle in that direction, but your hip is in that like externally rotated position, and you are bringing it up. So now again, we're going beyond that 90 degrees, and as you bring the leg up, you acquire that internal rotation of the piriformis, and now you're going to get that stretch because it's in an it converts muscle lengthwise from a external to an internal rotation muscle. The one thing that's significant about the piriformis is it's the sciatic nerve that runs inferior to it. So when we are diagnosing and we're assessing, there are special tests that we do to help identify, okay, is this coming from the lumbar spine or is it coming from the sciatic nerve? A lot of people say, oh, I got sciatica, I got sciatica. All right, well, the, I guess the health community has been professing this concept, and is it inaccurate? No, but they're going to say, oh, it's coming from the back or it's coming from the butt. Typically, you can actually get referred symptoms from the piriformis into the back. So it's kind of saying, okay, like, what is it? Is it more coming from the back? Is it more coming from the muscle? Because if that muscle gets irritated, it starts compressing on that area. That's what you're going to get. And so,
Uh, Anthony, I have a question.
yes.
So, how does the piriformis stretch actually look like? Is it when you have knees to the chest and you're pulling in, or is it with your hips externally rotated?
So I will go through that. I'm just going to set myself up here so I was anticipating anything. All right, so typically your external rotator stretch. Okay, this is one version. So you're here, you cross the leg, and then you're going to pull up. So I'm stretching my right piriformis because my leg is beyond that 90 degrees. Now it becomes an internal rotator. So how do you stretch an internal rotator? You put the hip in external rotation. This is external rotation. And as I bring the knee up and I pull, I will feel that stretch. Other versions of this is they call it a pidget stretch. So, like I said, when your leg is in this position, and as you bring the knee in, you kind of come up and you lean forward, you are also creating that stretch of the piriformis in the internal rotated position. So you are forcing the piriformis into external rotation when it doesn't want to be, right? Because it wants to be internal. Now, forgive me if I didn't explain it before. When we're talking about internal rotation of the hip, this is internal rotation. We're going out that way. External rotation. Internal rotation, external rotation. So think of external rotation as, oh, like, someone's like sitting like this in a chair. All right, that's external rotation. And internal rotation is the other way. So that's why we get a stretch of the piriformis when we do that stretch.
Thank you.
No problem. All right. Quadratus femoris, another external rotator. This is another deep muscle. We're talking about the distal branches of the sacral plexus. Like I said, these are, when you're talking about the lumbar plexus, you're going to have these branches off of it. So it gets into the, if I get the nitty gritty of it, okay, you're talking about L5S1. I tell you what, honestly, that's easier to say than like, let's go distal branches. All right, it's L5S1. You're not going to go crazy over it. The interesting aspect about this muscle, it externally rotates and adducts the hip joint. So you get an interesting combination there of, now, if anyone, I'm just going to go over real quick. So if we're talking about adduction and abduction, so adduction, right, you're going to add to your body. So if I'm here, this is adduction. If I step out, this is abduction. Adduction, my leg's going in. Abduction, ABD, is going out. So again, some of these muscles have that unique feature of performing that, and it adds that functional movement. So, clinical relevance. Why is this important? Relevant in patellofemoral pain, running, genu valgus. I'll go through that in a moment. Single leg jumping. For example, people who do ballet, kids playing. Honestly, kids play hopscotch or whatever. Stability of the hip. So this is important because if you do not engage those muscles, there's nothing to support, right? We need a support system in the hip. You have your acetabular joint, your pelvis, and your trunk. A lot of those muscles and surrounding structures, they're associated with a lot of that. Let me see. So you have a lot of these areas, these deep external rotators. Look at that. You have all this area here. So that helps stabilize here and here, which is what we're looking for in terms of the function of this. So that's why we work on in PT. We work on like that single leg stance. We work on external rotation, clamshells, um, because if they're not able to sustain that single leg stance or that position of pushing off, like planting or cutting, they can't. Their body will give out. Their leg may not turn a certain way, and especially if they're not functioning appropriately, it's going to affect down the chain. They're going to get that knee pain. They might get that ankle pain when they're trying to do something. Um, so, like I said, I didn't want to go too crazy into it, and I can go through it with you a little another time. Just some exercises. So these are specifically related to external rotators. There's, like I said, you're going to get a group. It's hard to isolate, but I'm assuming the idea of these are things that we can do depending on how the patient is, right? If they're having trouble standing, well, okay, we can do a sitting version. Working on single leg stance, sidestepping, prone external rotation, and hydrants. So we have the ability to have multiple exercises in different positions, right? So we have sitting, standing, side lying, hands and knees. That's great. As you change the position of the patient, you are changing the like it makes it more challenging. Typically, lying on your back is easy. Lying on your side, tall and kneeling, standing, single leg. So these are a lot of opportunities for us to progress a patient, right, with a certain exercise, and we're still engaging the proper muscles. There is an article that goes into from JOSPT I have here that talks about the importance and clinical relevance of the external rotators. And like I said, I have the pictures here. If you need pictures or diagrams of anything, like I said, I'll post and send this to you guys. Um, yeah. So like I said, I want to keep it short. Like I said, I appreciate you guys coming on. And let me just pause this so I can.